Our next speaker is Associate Professor Adam Dunn. Adam was one of the first postdocs I recruited into CHI, and I was really happy that he decided to accept the position, and then he decides that he was going to drive across the Nullarbor. So not only did Adam make it, but he's thrived here in Sydney. He's now head of Biomedical and Health Informatics at the University of Sydney. So, Associate Professor Adam Dunn, thank you.
Indeed, I did. Let me start by also adding my acknowledgement to the traditional owners of the lands on which we're meeting today. This is the land of the Wallumattagal, and pay my respects to elders past, present, and emerging. Today I'm going to be talking about adventures in measuring misinformation and its impact on health, although I've cheated a little bit because I've added in the word impact here, and I'm actually not going to be talking about effects or causality at all, or I might touch on it towards the end. So to start with, I thought I'd just quickly go through my set of disclosures. It's one of the areas of research that I work in, so I always feel like I have to do this at the start of all of my talks, and I've just put in bold the ones that are relevant to what I'm going to be talking about today here on this slide. So, as Farah mentioned, I arrived in the Centre for Health Informatics in around 2008, and my first boss was Farah. And we were doing agent-based modelling of patient safety in hospitals. My second boss in the Centre for Health Informatics was Blanca, and we worked on examining the impact of evidence on practice linking prescribing data to published evidence. And in this case, a lot of the things that we were doing were related to drug safety, in the sense of when we found out there was evidence that drugs were less safe than we first imagined, how quickly were they withdrawn from the market. My third boss in the Centre for Health Informatics was Guy, and Guy and I worked largely on building tools to improve the efficiency of systematic reviews, amongst other things. Interleaved across all of those programs of research, I developed a few programs of research of my own. And so one of them was about investigating biases in clinical evidence using citation and co-authorship data, and this was funded by an NHMRC project. One of the things that we're probably most well known for around the world now is on investigating financial conflicts of interest. And so we did a fair bit of work on that, largely unfunded, although it still pops up from time to time. And just over the weekend, I was helping a reporter from the Washington Post investigate some undisclosed conflicts of interest for vaccine production in Iran. I also had a program of research related to supporting methods to examine bias in clinical trials and systematic reviews. This work was largely done with Florence Bourgeois from Harvard Medical School, and we had funding to do this work from AHRQ, as well as an R01 from the National Institutes of Health and the National Library of Medicine. But I'm not going to be talking about any of those today. Today my job is to talk about social network informatics, and I'm going to be talking about vaccines, misinformation, social media, and anti-vaccine sentiment. So this is Suzhen Zhou, who was a research assistant before she joined my team in the Centre for Health Informatics, where she was a postdoc, and she's now an associate professor at the University of Southern Queensland. And one day, Susan, who was generally working on citation and co-authorship networks, we were having a bit of a chat. And we were looking at Twitter data because we were playing around with it. And I think back at those times, and I realise now how luxurious it was for us to have time to spend on mucking around with Twitter data. And I asked Susan, I said, you know, what should we be looking at for Twitter data? We could probably use this for research. And she said, I should totally look at HPV vaccines. Anyway, I thought that was a ridiculous idea, and I thought it would never work. She said, let's look at HPV vaccines, so that's what we did. And our first paper that we wrote in this area, which was led by Susan, was to see if we could answer the question, can we predict expressed opinions online? And so we used Twitter data. This is noisy, messy, text-based data, but it's not just text-based data, it's also social network data. And so what we collected was tens of thousands of tweets that were related to HPV vaccines, and we looked at the text of those, and we also looked at the people who those users followed. And so we built some machine learning models. We used machine learning to be able to predict people's expressed opinions by labeling a whole bunch of them. And we used the language of the tweet. And so, of course, you can build a machine learning model that uses the language of the tweet to predict whether or not that tweet is going to be vaccine critical. At the time, we would just call it anti-vaccine, but we've moved on. And turns out, yes, of course, you can build those models. But the problem with those models is that the topics that people talk about over time, they change. And the words that people use change as well. And so while we built those models and we trained and tested them on one set of months, if we then took those models and applied them to the next set of months, they didn't work so well at all. They actually failed and degraded quite quickly. And that's not a surprise because the topics that people say change quite quickly. However, when we built models, machine learning models, that use the network connections, the people who you follow, as the features in the machine learning model, not only were we able to predict people's expressed opinions using only the information about who they follow, but those models didn't degrade over time when we applied them to future tweets and future users. So that was a really interesting finding, and it would kind of set the tone for the kind of work that we would do for the rest of this program of research. This is Paige and Dee Dee. Dee Dee's in the audience today. Paige was a software engineer and is now a software engineer at Atlassian. And Dee Dee is still here in the Centre for Health Informatics as a research fellow. And together, we would, with a team of other people as well, I should say, we were looking at whether or not people's topics, the topics that they talked about, clustered within certain communities, whether people were talking about different things. And of course, the answer is yes, but we really needed to quantify this. And so we used two methods here, two kinds of clustering methods. One was called topic modeling, which is about taking lots and lots of documents, in this case tweets, to try and cluster them into topics. And we also use community structure algorithms, which is a network analysis method which takes the structure of the follower networks and then tries to determine the community structure of those. Surprise, surprise, when we put those data together, we discovered that not only are the topics clustered within communities, but that we were able to build this kind of nifty way of trying to label and categorize the topics. And so we use this, I like to use this idea of Sesame Street. One of these things is not like the other. It's kind of the odd one out approach of manual validation to build a hierarchy of topics. And the topics, of course, span from very vaccine critical topics like scandals and conspiracies and side effects through to experiential things where people are talking about going to get their HPV vaccine, through to things like clinical evidence as well as public health advocacy, including things like this is where you go to get your vaccination. And so, of course, we discovered that there were clusters of communities of people on Twitter who were mostly sharing topics that were negative. There were other clusters where people were mostly sharing things that were positive. But interestingly, we discovered that there were communities of people who were only tweeting about their experiences with HPV vaccines, and these people were not actually engaging with the positive things. They weren't being exposed to positive messages about public health advocacy, and they also weren't being exposed to negative things. They weren't part of the anti-vaccine communities that were spreading messages about side effects online either. So that's interesting that people's information consumption and information exposure can vary quite considerably across their communities. Kind of not surprising, but also kind of something that was interesting to be able to quantify, and we were the first people to be able to do that. So all that's kind of nice, but we think about that and that's just information that people are posting online. It has nothing to do with real world outcomes. And so we actually were interested in if we could connect the things that people's information consumption and exposure to some real world outcomes. And we did this. So we looked at vaccine coverage, HPV vaccine coverage in the United States and in Australia. And part of this team was Amelie Dida. And so Amelie Dida joined us pretty soon after she finished her PhD, and she's now a senior lecturer at the University of Queensland. And so what we tried to do was to build models to see whether or not the topics that people were exposed to was associated with vaccine coverage by location, by region. So these are ecological study designs in the sense that they compare a population to a population, even though those populations may be sampled quite differently. And so this is an example of the Australian one, but largely what we discovered was that we took the timeline of all HPV vaccine-related tweets that had appeared over several years, and then we sampled populations by location, by city in Australia or by state in the United States, and then we looked at the billions and billions of social connections between them to see whether or not people were likely to be exposed by certain types of information. And so we discovered, of course, not surprisingly, that even when we added in confounders and other parameters into the models, including income, insurance, and other things, that the exposure at a population level to negative topics, to topics that were vaccine critical, was associated with lower rates of vaccine coverage. And remember, I said at the start, I'm not talking about impact here, I'm just talking about association. So it turns out that locations where the information ecosystem that sits around people is more filled with topics that are negative, it also correlates with lower rates of vaccine coverage. This is Zubair and Jason, and Zubair is now an assistant professor in Qatar, and Jason works with me at the University of Sydney as a software engineer. And we weren't just interested in whether or not we could connect associations between people's information exposure and consumption with their with vaccine coverage at population levels, but we were also interested in to see whether or not we could build some tools to support changes, right? So these are tools that might be used to help pre-bunk or debunk myths that appear online. And so in this work, what we did was to collect up tens of thousands, hundreds of thousands of web pages that were posted as links on Twitter, and we were trying to build a tool that would be able to predict the credibility of those web pages based on the text that was on them. And so, of course, we could do this. And so Zubair used deep learning methods in NLP to be able to predict a credibility score, or at least which of the criteria of credibility criteria were met by those web pages. And those criteria were based on two common methods or two common tools. One was Discern and one was QIMR. Discern is based on is a credibility rating for patient information, and QIMR is a credibility rating for media releases and science. And of course, we discovered that yes, we can build a tool that can reasonably accurately assess the credibility of any piece of text on any web page, which is nice to know. We never translated that into a tool that could be used for pre-bunking or debunking, but what we did discover when we looked at excuse me, when we looked at all of the web pages that were being posted on Twitter is that by and large, medium and high credibility web pages were getting more eyeballs. More people were following the people who were posting them in general. However, there were still hundreds of low credibility web pages that were receiving or had at least 10 million followers who could have seen those tweets. So there is some risk associated with low credibility web pages being posted online and having high views, if you will. So in parallel, lots of computer scientists and lots of physicists love to write studies on misinformation. And that's nice because it's always good to get some new ideas and new fresh perspectives in the area. But one of the problems with that is that a lot of the work they did was just to count up misinformation online, not consider the denominator, and not connect it to any real-world health impacts. So that wasn't connected individually to people's attitudes or behaviours, and it wasn't connected at the population level to the vaccine coverage outcomes, for example. And so moving to general vaccination now, we were worried about studies that were speculating that bots were having an impact on the spread of misinformation. And we knew this not to be true based on the work that we'd done in these previous studies. And so what we did here was to look at, by sampling 50,000 people, 50,000 users who were on Twitter in the United States, and looking at just what kinds of information they were actually being exposed to and which kinds of information they were engaging with. And you won't be surprised to know that less than 6% of people, of users on Twitter, were being exposed mostly to vaccine critical information rather than vaccine neutral and vaccine positive information. By and large, most people are exposed to lots and lots of information about vaccines all the time. Very little of that is actually vaccine critical, and they engage with that even less. And when it comes to bots, it's even less than that. It's so negligible, it's not worth talking about. Despite that, people were writing lots of studies in the area. And so we sought to correct that. This is Mareka Steffens, who was a PhD student in our group. Mareka is now a research fellow at NCIRS and working in a job that's halfway between policy and academia, which was her dream job when she started a PhD. And so Mareka's background was as a journalist, and she was really interested in supporting public health organisations and journalists with practical tools that they could use to try and deal with myths and debunk myths online. And so Mareka undertook a number of studies, but one of them was this trial. And so this trial, she looked at the presentation of debunking messages and to see whether or not there was an impact on people's belief in myths after they'd seen it, as well as a week after they'd seen it. And so, short version of this, turns out that no matter what presentation you use, whether that is that you put the myth up front, whether you put the question up front, or whether you have a statement of fact up front, all of those reduce the belief in those myths. Although I would recommend reading the study because there were some subtle nuances that were really interesting about this as well. So we've talked about all of these things that we've done. We've talked about measuring misinformation online, about information consumption and exposure, about its potential associations and correlations with things like vaccine coverage and vaccine outcomes. But actually we're still missing a key aspect of this. And so that's some of the work that I'm now doing in my new role. And so while I spend most of my time looking after this bunch, actually this is half of the bunch that I look after in biomedical informatics and digital health, we're also working with the World Health Organization to build new tools to be able to measure people's information exposure and consumption and link it individually to their health attitudes and behaviours. So for example, with the World Health Organization, we're building tools that on your smartphone take just 4 or 5 clicks to be able to record information that you might see, not just online, but in conversations with your doctor, on billboards, conversations you might have on WhatsApp. And those tools are very simple things, and we're giving them away for free as part of a study platform so they can be used across regional networks around the world and in resource-poor settings. So that means that study investigators from all around the world will be able to easily conduct studies to be able to measure and understand people's links between information consumption and information exposure, and then connect that to their health attitudes and behaviours. And so that's what we're doing with the World Health Organization. Hopefully it will lead to a global surveillance system for evidence, and the reason why is because each of those study investigators can just click a little box, and that little box says, contribute my data, my de-identified data, to a global meta-analysis of these studies. And so that's what we're doing now. So to end, I've just put a list of some of the references that we produced during this time, and the acknowledgements at the bottom are all the people that I didn't put on the page, but who were contributors to one or more of those studies that I talked about. Thank you very much.